this is the second part. It's dealing with retinal detachment. The causes, of course, you all are familiar, but just to let you know about the development. You know that the posterior vitreous detachment is the cause. All aging people are developing it, so mostly after 70 years, you find it in 60%. If the patient is older, it's nearly there, more than 90%. You may have symptoms if you have this PVD, so floaters or flashes of light, or in most cases, you have both. You have the risk to develop a tear in 12 to 60%, mostly when you're having symptoms. But also if the first examination didn't show you any tears and it was an uncomplicated PVD, there is a risk of 3.4% to develop a tear within 6 weeks. So it's important to do a follow-up twice, just to be on the safe side. And especially if you have a vitreous hemorrhage, it's very dangerous, because in these cases there is a high risk to develop a tear, and mostly in 90% they are superiorly located and the patient don't have any history of blood pressure, diabetes, or he takes any medication. So this patient you should really follow up very, I would say, so 1-2 days afterwards, do an ultrasound, and if it's not resolving, I would go for early vitrectomy to be on the safe side. This was a case who had a history of a tear and a laser treatment. You see he's phakic and he has a bleeding which didn't resolve. The problem with bleedings, you all know, is that you don't have a good retroillumination, so you have two choices. If you do vitrectomy, you can use either a channel gear light or like this. You can just plug it in, or you take a membrane blue to stain the capsule. It helps you also, like in more mature cataracts, to see the capsular bag better and to create a proper axis. And here, if you just move around, you see from no red reflex, you're getting a quite good red reflex. And it's also important that you can do a normal cataract surgery without creating any problems or tears or injuries of the capsula. So this is another machine. This is the Dork Ether, and this is 27 gauge. You don't see the different colors. And this is a standard intraocular lens. It's a technique from Ammo. We did the corvitrectomy. Now I removed the posterior blood in the center of the macular area. You can also use the fluid needle, and here you see there's the indentation from the outside. This is the old tear, and there was some attachment from the vitreous, and this caused the bleeding. And now I'm cleaning the periphery with indentation from the outside, and I do again a laser treatment. And the rest of the hole was without any subretinal fluid, so I didn't did any air bubble filling or something like this. I just kept it without any tamponade. So regarding the treatment, there is one type of tear. It's a symptomatic horseshoe tear you have to treat, because if you don't, you get a detachment in 30 to 50%, and with laser treatment, it's only 5%. What about the recommendations? When I started to do my training, all colleagues told me they should not read, they should not do sports, they should sit watching TV is okay for at least 1 week. But it changed, because we know that during the sleeping phase, there are the REM phase, the movements of the eyeball are heavier than doing anything like the restrictions. So if you have a patient with just a PVD, no restriction. The same is for laser therapy. He can do whatever he wants. I wouldn't recommend that he does a lot of running, maybe the first 2-3 days, and but he could if he would like. And if you have a PVD with hemorrhage, there are also no restrictions, but close follow-ups unnecessary. And the most important thing is that you talk to your patient, that you explain him what he is having, which diagnosis, which risks, that he know when he should go to a follow-up, and that it's important to do a follow-up. If the worst case is happening, a detachment, you have 3 options. You have the pneumatic retinopexy, you still have the scleral buckling, and a third option, you have the pars plana vitrectomy. So if you compare these different procedures in similar cases, they are quite okay. But for pneumatic retinopexy, there are some other indications, because here you should only do this procedure when you have a single break, when the detachment is superior, you don't have any PVR formation and no glaucoma, then it's working very well. It's a procedure from the mid-80s, And you can do it as an outpatient procedure, even at your office. And I don't know, is it popular in one of your areas? Yeah. In the United States is also very common. In the United Kingdom also. In Austria it's not so popular. We do more scleral bucklings than the retinopexies. This is the procedure. You give an injection of a gas, so you have again the 3 different gas options, and you combine it with a transconjunctival cryotherapy or laser therapy the day after. And you see that in these easy cases, the single operating success rate is very high, but if it's failure, you have really problems with a severe PVR formation, and the surgery is not easy. Scleral buckling was very common. You can do it as a radial scleral buckling or an encircling band. It's more common in phakic eyes and in young people, and then you have a good single outcome procedure. But in pseudophakic, in aphakic eyes, it's not working very well, and of course it's not working if you don't see any intraoperative break, because without any breaks you can treat it properly. And the vitrectomy is getting more and more popular during the last 10 to 15 years. You see the tears quite good or even better. It's more atraumatic. You don't have to deal with all the muscles and the sutures and with the sclera. So it's easy putting the trocars in. You have a panoramic viewing. You don't have to use any devices like the indirect ophthalmoscope or anything like this. And you don't cause a lot of change in refraction, because the sclerotomies may induce a little bit of an astigmatism, but nothing else. Again, the big problem is the cataract formation, so also in detachment cases, combined procedures are a good option. This is a case male, 55 years old. He had a small retina detachment. This is again a combined surgery. This is 25 gauge. This is the blue color of the trocars. It's again the Alcon constellation. We do a standard cataract surgery. He has not a big cataract formation. This is the ocil tip from the Alcon machine. We put in a standard lens. And in the detachment cases, because I do a lot of indentation, I prefer to put a suture on the cornea, which I remove afterwards. Here you see it. And now we do the anterior vitrectomy. We go inside, we do the core vitrectomy. You see that the detachment was already there, so we didn't have to induce it. Now I use heavy liquid, a PFCO bubble, and afterwards I like to use in my detachment cases triamcinolone, because I see the vitreous much better and I can clean the periphery much better. Here you see the tear, and the indentation from my fellow, and I do the cleaning 360 degrees, that I remove as much extraction as is possible. And I mostly do the laser treatment under the heavy liquid. And then you have the option to remove the heavy liquid and then put an air inside, or you do a direct exchange. In this case, I've removed it first, but now I switch, I do it directly. It's a little bit more, it's easier and it's not lasting so long, and you see the bubbles very well. Then I remove the trocars at the end after the gas fill, and these cases I suture, even if it's 25 gauge, because I want that the gas bubble stays as long as possible in these eyes. And the sutures don't bother the patient a lot, and I feel more safe because I don't want that the bubble goes away and then the detachment is not supported anymore. I have another case. This was a little bit more severe, a bullous macular off detachment. Here you see just the OCT for the main incision. Bless you. This is 25 gauge. This is again the dog machine. He was taking tamsulosin, so he has a very floppy iris. This was quite challenging during the cataract surgery because you will see that the iris is really mobilizing towards the outside of the incision, but you can also do the surgery quite okay. You can use some devices to dilate the pupil again, but normally it helps not too much. But the surgery was okay, and I put in some different lens. It was from another firm. You see the blue haptics. It is from Polytech. It was also a preloaded intraocular lens. In this machine, there's one difference, because here you see again my suture of the corneal incision, which I remove after surgery directly, not some days later. And this machine has these plugs, and to have more stable infusion pressure, you remove these plugs in the small gauge systems. This is 25 gauge, and you put the infusion line like this. So you have a little bit more stability. Again, the anterior vitrectomy to clean whatever you see at the anterior part. This is the bullous detachment. He also had a PVD, and now I put in the heavy liquid as in the other case, and again the triamcinolone. I don't know exactly where his tear was, but I think it was quite peripheral. Yeah, because now it's flat, and again we do the 360-degree indentation, and then the laser treatment. You can also do the laser treatment under air if you want, because then you even have a more panoramic view, and this is the PFCO air exchange, and then comes the gas bubble, and now you see the removal of the corneal stitch, and again my sutures of the sclerotomies. So what's important in these cases that you're sure that there is a posterior vitreous detachment. If you're not sure, you don't have to use triamcinolone because the crystals are mostly very sticky to the macula. You can only also use a blue dye, like in this case. The blue dye also stains the vitreous very nicely. And this is again the dog where you have to remove the plaque. And sometimes, if I'm not sure, I do the blue dye first. This helps me also to see if there are any membranes at the macula. And here you see it's completely attached. Mostly this also looks in macula hole cases like this. And you see you can nicely create a PVD, and you see that you detached everything. So we have different tamponates available. If you have just a big tear with a little bit of subretinal fluid, you can also consider air, but mostly it's a little bit more, and you go in between SF6 and C2F6. I prefer mixtures that don't have an expansion because it's more stable and I know the bubble is big. I'm not a fan of this one because if I need a long-lasting gas for 2 to 3 weeks, then I think it's more safe even to use a silicone oil, because this is just waiting longer than if you use a C2F6 gas. But you should use the shortest acting gas which you think is working. This is again a lot of literature, so comparable outcomes regarding vision and healing rate between vitrectomy and scleral buckling. The only thing, if you have a very young patient or a young patient, you know that the detachment of the vitreous could be very tricky because it's really sticking at the posterior pole, and these patients are still a good indication for scleral buckling. Because if you do a vitrectomy in a young patient, you can get a lot of problems with PVR formation and even have more surgeries necessary than with a well proper placed scleral buckle. The side effect of the scleral buckle is that if you do an encircling band, you can induce an amount of myopia. If you have to suture the buckle near the muscles, diplopia can occur, and if you have to drain, of course, there can be complications due to drainage. So if you use this procedure, try to use a segmental if possible and non-drainage procedures, or if you have the special indicates, then a pneumatic retinopexy is for sure a good option. In the Anglo-American area, young fellows and residents are not trained for scleral buckling procedures anymore. They do vitrectomy or pneumatic retinopexy. In Europe, we did a lot of buckling procedures, but it's becoming really rare, and we also are not very well experienced in doing this. So this is again evidence-based literature with comparable outcomes. These are all the randomized trials. And this was the big breakthrough regarding vitrectomy, also in Europe, because this study is the famous SPR study, which found that in pseudophakic eyes, primary vitrectomy is more effective than scleral buckling. And this made a change regarding the choice of the procedure in Europe. This is also some literature if you have to put a scleral buckle in addition to a vitrectomy, because this was common when I learned to do surgery. We put the scleral buckle, we put vitrectomy, and we used silicone oil. So we did an overtreatment in our cases, and just to be on the safe side, and this is why they also did some researches regarding this. This is the Hyman, the SPR study again, where it was quite awkward and nobody could explain why in the phakic eyes an additional scleral buckling had worse outcomes than in the pseudophakic group. And we did this study to try to avoid the additional scleral buckling, and it was very hard because it was a very long learning curve. We had to learn that we do a proper indentation if we don't put the scleral buckling, and this study was okay, but we used a lot of silicone still there, but the results were comparable. So what we learned also is to go away from silicone oil. These are other multi-center studies in Spain and in Portugal, where you see that the rate of primary vitrectomy was increasing in pseudophakic and in phakic eyes with the same outcomes. Here, the United Kingdom, you see that most common vitrectomy was used, less silicone oil, sometimes with cataract surgery, but not often with an additional scleral buckle. And this is also a multi-center study from the Evers Society. Here they do in phakic detachments. I don't know the age period of these patients, mostly scleral buckling, but in pseudophakic, a vitrectomy without a buckle. This was a study we did with White Cornell, because I was there and did an observership, and you see, it's amazing. In this time period, we did 90% scleral buckling, 66% scleral buckling, had a good outcome, and they did 83% vitrectomy. And if you look at the time frame, our percentages regarding vitrectomy is increasing, and now I think we even do 98% primary vitrectomies. So this is also important. If you have a patient with fresh symptoms, what is the risk that when the fluid is coming to the macula that the fovea gets off? So it's about 3% without bed rest and 1 to 2% if the patient is doing bed rest. Before the surgery become famous, they always patch the eyes that the eye can't move. And in these cases, the surgery is recommended to do early. So if it's bullous, if you have the tear in the superior temporal part, try to do it if possible within the first 16 hours. If you have, if you have a macula off, these studies investigated the duration of macula off detachment. They didn't found a big difference, but which I would recommend is that to do the surgery also within 1 to 3 days if you have an ER. I wouldn't go to the emergency room or to the OR room at midnight, but I would try to do it also as soon as possible, because the cells are damaged when the macula of detachment is longer than some days. So surgery is more urgent in a macula on detachment, of course, but you have the OCT, you can see how threatening the macular situation is, and a short delay of 1 day has no influence. If you have a patient with a history of a macula off detachment longer than 1 or 2 weeks, you can wait long, a month or whatever. So this makes no difference. This is an interesting case. We had a patient, we thought he had a macula on detachment, and he didn't recover very well regarding his visual acuity. So what we found during surgery using the intraoperative OCT, there was, when he was sleeping, a shifting of fluid, and this may be the reason why the visual recovery was a little bit limited. So sometimes if you think the macula is attached, it's not really true. The OCT helps again to see how much damage has been, or is it only threatening, or is the fovea attached? You see the different pictures. And you know about metamorphopsy, that this case is wonderful, has no metamorphopsy, has a good postoperative vision. This patient has also a good postoperative vision and no metamorphopsies, but this patient with no ELM or ellipsoid zone has severe metamorphopsia and only a vision of, I think, 220. What's the risk? I don't know why, it's more in younger patients, of course macula off, if you have subretinal fluid and if the membranal limitan externa is disrupted. So here you see again the development. This patient did very well. The first time the vision was not too good. It was 20/50. After 4 months, it really resolved, and he made 0.9, and this is after 8 months, so you don't see any irregularities, and his vision is 1.0. So he did a full recovery. And also the cone density is important in these cases. If it's normal, then you have a good OCT results and you have a good IR scan. But if you have a loss during the macula off detachment, also the visual acuity is affected, and you see the changes in the OCT and also here. Another important side effect of silicone oil is an unclear vision loss, which may occur in about 5.9%. We don't know why. They did studies in cadaver eyes. They found some droplets in the optic pit and in the macular area. They might have high IOPs in these cases. Sometimes light-induced damages are discussed, and the duration of the tamponade, and it was more frequent in female patients. So it's a pity, but this can really happen. I also had one female patient, her vision before silicone oil removal was 0.8, and afterwards she only had, I think, 0.1 to 0.2, and we didn't find any reasons. So what about macular slippage and the folds, which can really affect the vision? It's again discussed, should you position directly after surgery or should you wait? Should you face down your patient, not depending where the break is, or will heavy liquid protect it? Again, no consent. Some studies say yes. These are all randomized clinical trials. Others say there is no difference, and a retrospective study suggested that expanding gas bubbles and no posture may lower the rate of macular shift. So again, we don't know what to do. I like to position my patient directly after surgery, that I don't have any residual fluids afterwards. This again are some PET service questions. So this is the case which indicates the choice for primary sclerobuckling, a very young patient with a small detachment and where the highlight is for sure attached. This is not a young patient. She has a small detachment on the inferior part, macula is on, and you see that also here the majority would do a sclerobuckling, and a third would do a primary vitrectomy without a buckle. So I think this can be discussed. I'm not sure if I would do a scleral buckle because my training is not so well regarding the scleral buckle, and I would feel safer with a vitrectomy. And 45 years with a PVD might be treated with vitrectomy very well. So this is the PET survey regarding COVID patients. So if you have 1-day macular off detachment, you see that all would do surgery as soon as possible, regardless of he is COVID positive or not. What about this? This was a traumatic scleral rupture. A patient which in the ultrasound they found a macular off detachment. He has also a vitreous hemorrhage, but no PVD. He's young, he's phakic, 35 years. So you see that the trend is to do it within 3 or within 1 week. So it's a discussion. I don't know how much the center is involved or not. But of course, he's young, so I wouldn't wait too long too. What about encircling bands in giant retinal tears? You see that it's not so common anymore as it has been years ago, so the majority of cases don't add an encircling band. This is the classic pseudophakic detachment, macula on, 1 tear. She's not young, she's slightly myopic, so vitrectomy without buckle is the standard procedure. And if it's an easy detachment, I prefer 25 gauge because 27 is not a good option for me because the instruments are too flexible, and 25 gauge is perfect. I don't use a scleral buckle in these cases, but suture I recommend it for phakic and pseudophakic detachments, and I do cataract surgery if necessary. I always like to use triamcinolone and scleral depression. I mostly use PFC, except for a large tear which is in the periphery and not a lot of fluid is present around, then I wouldn't use it. I use endolaser. Other health care systems like to use cryotherapy. Also in Y Cornell, where I did the observership, they preferred cryo. And I like to use gas, if possible, the shortest acting gas. If it's a more severe case, then I go for 23 gauge, or I just use 1 trocar 23 gauge that I can do silicone oil fill if necessary, because I don't use a light silicone. I use the 5000 centistoke silicone, because if I need it, I want that it's a more proper and not so emulsification risky silicone oil. And there you need 23 gauge to put it in. So global pathologies, PVR, history of multiple surgeries are these cases. And if you have a young patient, then I would go for an additional scleral buckling to support the anterior vitreous base, because they are shrinking really very, very fast. And in these cases, the scleral buckle is a good option. Otherwise, I would go for a retinectomy to relax the PVR folds. And if I have to do a big one, then I would go for silicone oil, but try to remove it within 3 to 6 months. Okay.